everyone, welcome to UC Max Grand Rounds. My name is Britt Guest.
And I'm Scott Kobner. Welcome, everybody.
Woo! I want to start the show off with a very exciting announcement. So for our headlines, bottom lines, our very own Gita Pensa was on Dr. Glockenflecken's podcast recently, and she talked about litigation in the medical kind of field. She talked about a personal story that she shared. Super awesome, and it was just like total, all the stars. Yeah. Dr. Glockenflecken, Dr. Pensa, it was so rad.
It's a pretty awesome episode. I think the podcast is called Knock Knock Hi, because all the comedy bits where he pretends to be like a med student awkwardly coming into the room, you know, or all those fun situations you remember from school. It's a really moving piece. It's on YouTube, I think,
yes.
also on Spotify. It's
yes.
all free. You should check it out. Gita does an incredible job on it. Her personal story with like litigation, med mal experience
Crazy.
Is really awesome to listen to and inspiring. And also she is a great coach for that stuff. If you're listening and you're out there, maybe you're going through that experience.
Yeah, I think we don't talk about it very often, but tons of us, most of us get sued. We go through this process, and she really points out that we don't have to do it alone. And she provides support for a lot of physicians going through a similar situation. So.
Plus, and while you're over there, you can check out some of his funny, hilarious
videos.
videos.
Super hilarious. All right. We have some really awesome people in the studio with us tonight. Who do we have, Scott?
Amazing list. Before we even get to the faculty, we have an honorary faculty this evening. So we've been doing this for over a year now. And
almost two.
Almost two. I want to shout out to David P.
Woo!
in the chat. David P. has been with us from the beginning. He's almost always the first one on. Honorary faculty of the evening. We love seeing you there, David. Thanks for joining us. But we got a bunch of other great people in the studio tonight.
Yes.
We've got, of course, Mel Herbert. Oh, there he is. That yell down the hallway. Iconic. We've got Sean Nort. We're joined by Paul and Armand. We got a crew that's extending from Loma Linda to GW to LAC to UCLA. A whole bunch of people ready to talk urgent care this evening. Who else we have in the chat?
Right. So, of course, we have to have our UC Max professors. So we've got Mike, we've got Gita, we've got Josh. They're all in the YouTube chat. So put any and all of your questions in there. We can have a really active, dynamic conversation. They'll answer all your questions. It'll be awesome.
Yeah, and I think we also might have a Stewart Squadron's sighting. I've heard that he might be in the building, so he might be making a guest appearance.
We might see him in the show.
Okay.
Potentially. Get excited. All right, and then there's like a doobly-doo.
The doobly-doo. Yeah, so if you're just joining us for the first time, we do these grand rounds every month. We alternate between urgent care and emergency medicine. So like, subscribe, hit the little bell down in the doobly-doo below. We're obviously monitoring the chat throughout the show. We'd love to answer your questions. We're going to do some polls. So join us so you're always alerted. And if you're joining us for the first time, have a great night. It'll be a fun hour or so of some high-quality education. We're really excited to share with you all.
All right, we've got a jam-packed show, a ton of faculty. What's our first segment?
I think we're going to Images of the Evening, Britt.
Let's do it.
Let's do it.
It was all a dream. It was all a dream.
So, for clinical images of the evening, we are going to be joined by Mike and Gita. We sat down with them, asked them a couple questions, showed them a couple images, and really excited to hear and share their thoughts on some of these pictures. So, without further ado, our first clinical image. This is an 8-year-old female. She's coming in with left eye irritation, kind of itchy, increased tears, no other symptoms, no trauma, no discharge. What do you think, Mike and Gita?
Okay, so this is a 10-year-old who comes in with looks like eye irritation, itchiness, some increased tearing. I think on first glance, I see that it's affecting one eye. There's a lot of hyperemia. It looks like there's some tearing. If it doesn't sound like it's terribly, terribly painful, which is what it would sound like with a corneal abrasion, I would think looking at this, the most likely diagnosis would be conjunctivitis. What do you think, Mike? We should probably talk about how we differentiate between viral and bacterial conjunctivitis.
Yeah, and that's a really big differentiation for us, of course, because bacterial is going to be what people think of as being some sort of pink eye, which has this huge moniker of like, oh my God, it's pink eye. They have to stay out of school. And in the end, probably 99 out of 100 pink eyes are viral conjunctivitis, not bacterial. So the things that lead me more to bacterial are a lot of purulence, And sometimes patients will have a clear eye, and you'll ask them, how about when you woke up this morning? And they said it was matted shut, but we wanted to come to see you in the urgent care and get it all clean before we saw you. It's like, well, maybe that isn't the most helpful for me for making the diagnosis. So asking how it was before they got to the urgent care is important. A patient who has really significant conjunctival injection, a patient who lacks any of those viral type of symptoms, such as runny nose or coughing, as well. The last thing, and the super important thing to differentiate, is that if they have that redness not generalized in the conjunctiva area, but more around the limbus, so around the colored part of the eye, that limbal flush would make me think of an inflammatory process such as iritis, uveitis, not a viral or bacterial conjunctivitis. But Gita, I 100% agree. Looks to be viral conjunctivitis.
Yeah. And then if we decide that it's viral conjunctivitis, then, people always come to the urgent care asking for drops for pink eye. But typically for viral conjunctivitis, I talk to them and I tell them it's just like a cold anywhere else, cold in your eye, and it's going to get better on its own within the week. Now, if there's a lot of discharge and you can't tell, it seems like most of America can't go to work or can't go to daycare without drops for their pink eye. And so sometimes I just, we'll talk to them and do some shared decision making around making that decision. How about you?
Well, this is such an important thing to bring to this program because taking this to the bedside at the urgent care, we see this so frequently, and it's a little bit high risk in the sense that patients have this expectation that it's pink eye and they're going to get a prescription for antibiotic eye drops. And as you know about me, I've never been that guy that thought everyone needs to leave with a prescription. But what I do think they need to leave with is a diagnosis and reassurance. So if we think that this is viral conjunctivitis, I would say lubricating drops or nothing and reassurance, let the kid go back to school and do not give them the antibiotic eye drops.
All right. So Mike and Gita are right. This is a case of viral conjunctivitis. In fact, coming up on UC Mac's December episode, there is going to be a segment on viral conjunctivitis. So check it out. We had a poll going on in the YouTube chat, and we were looking for, would people prescribe antibiotics for this? Sounds like about 73% of you said no, you would not prescribe antibiotics, which I think is totally appropriate. I will say, sometimes I'll give a little bit of erythromycin ointment, really just for lubrication, can help with some of the discomfort. But you're right, it's viral, doesn't need antibiotics. Moving on to our next image. This is obviously an eye, the back of the eye. The story goes with this is a 68-year-old male. He has a past medical history significant for some hypertension, some diabetes. He's coming in with 1 day of vision loss, painless, no other associated symptoms, and a normal neurologic exam. So Mike and Gita, would love to hear your thoughts on this one.
So I love this question because I love thinking through a differential diagnosis. And when you think of something broad like chest pain or shortness of breath or headache, it's a huge differential. But when you think of something specific like this, it's not just vision loss, but it's painless visual loss. I think of a central retinal artery occlusion, which is a stroke, really. I think of a central retinal vein occlusion. I think of a retinal detachment, although that's going to be usually pretty obvious because it's going to be that curtain. So it's not going to be the whole vision is lost. It'll be part of the vision that gets lost. I think of a patient who might have a vitreous hemorrhage, although that's a little bit unusual. And hopefully by doing the exam, we'll be able to come into that. And then finally, with painless visual loss, I think of something like an optic neuritis, which wouldn't necessarily be painless. Certainly a foreign body wouldn't be painless, but those are other things at least we could consider as far as a patient that has vision loss.
That was a great list, Mike, of all of these things that we've got to consider. I do think that this image is fairly characteristic for a central retinal vein occlusion. And what you're looking at here is, you see these like cotton wool spots, and you've got retinal hemorrhages and these tortuous retinal veins. Looks like everything is edematous. Like that's sort of your tip off for a CRVO.
Yeah, and I have to tell you, in sort of a bit of a self-deprecating way, always had a difficult time differentiating between central retinal artery occlusion and vein. And the way that I like to think of it is with an artery, it's occluded, right? So blood's not going into the eye. So it's going to be pale, except for that cherry red spot, right? Where the maculum, the fovea centralis gets its blood supply. Whereas the central retinal vein occlusion, the occlusion is from the blood leaving the eye. So the blood is like pounding in, it's going in, and the blood vessels like, I'm going to hold. And then finally, I can't hold anymore. They spill the blood into the retina and you get that blood and thunder appearance, which is what this looks like.
And so in terms of the disposition, if I saw this patient in the urgent care, it's a little different than the central retinal artery occlusion, where if you're seeing that person in, a short period of time after the onset, you're going to really think stroke, and you are going to send them bells and whistles, sirens flaring to the emergency department. However,
Right. Yes.
This is a little different. This is a little less time sensitive. And this is something where if you could talk to an ophthalmologist and get that patient referred so that they could be seen in a timely basis, I would be comfortable with that. How about you?
100% agree. This is the patient to take that extra time with, to find the retinal specialist that's closest to you, to call and to get that person on the phone and say, can you see them in their office? I have done this many times. I've never had an ophthalmologist say no. The patient is directed to their office, and whatever they do, whether it works or not, hard to say, but at least they're seeing someone that has specialty with this type of thing. You do not want to play games when it comes to someone with vision.
All right. Absolutely. This is central retinal vein occlusion. I always think of this as kind of like the DVT to the eye versus central retinal artery occlusion, which really is a stroke. That's a stroke to the eye. That's a clot in the arterial system. That needs to go to the emergency room. All right. So third image, a little bit interesting here. You have a 3-year-old. Mom's coming in with her 3-year-old. They were hanging Christmas lights, and the little 3-year-old turns to mom and says, I ate Christmas. So a little bit concerned about a foreign body ingestion here. You get this upright KUB, and you see a little something. Mike and Gita, thoughts?
So this little boy told his mom, I ate Christmas. There does seem to be something sparkly, shiny, glassy in that picture. So that's a little worrisome. It looks like a little light bulb. If I had to guess, I would guess it was glass. It doesn't look to me like a LED bulb. And so that is also very concerning. And to me, Mike, I don't know. I don't think this is in the stomach. This looks to me, it's always hard to tell with just this one view, but unless I'm being faked out by overlapping shadows, it looks to me like this is in the intestine.
Yeah, I agree. And when you think about, well, what do you need to do this sort of thing? It sounds super scary. If this was my kid who had a light bulb, like a bunch of glass, potentially that could rupture in their bowel, wherever it is, right? I would be super concerned.
Yeah.
On the other hand, I think to myself, like, no one is going to do a open laparotomy and go into the intestine to take this thing out, especially if it's already passed from the stomach into the intestine.
Yeah,
right?
there's endoscopy's not going to be able to. They're not going to be able to get that. A lot of times, if you have a foreign body that you're worried about with a pediatric ingestion, and it's gone past the stomach, and it's not going to get to be retrieved that way. Oftentimes we will watch and wait and see what happens, because you're right. They're not going to do an X-lap and take this out. And so the question is, can that happen at home, or is that something that should happen perhaps in an emergency department or with an admission to the hospital? And this is something where, I think you would really want to do some shared decision-making with the family, but I would feel more comfortable if this child were being watched with serial abdominal exams, because if this were to fragment, it could cause a lot of damage. And I would rather that child be in the hospital than the parents trying to decide, should I bring them in? Or, I would feel more comfortable if this child were in the emergency department.
Well, what advantage you have in the emergency department is that specialty consultation and the ability to watch. But I'm also thinking with this light bulb, small light bulb, which will probably pass on its own, what would happen in the ED? Now, would the patient get admitted? My guess would be probably not. And if it doesn't rupture, we're probably not at a significant concern as far as emergency surgery. The way that I would do this in the urgent care is I would call my local pediatric hospital. I would talk to the emergency clinician that is there. And I would say, what do you think? Is there any utility for sending? And they might say something like, well, why don't we just have them follow up in the GI clinic tomorrow or see their primary care clinician tomorrow? Or they might say, and maybe this is my lack of knowledge about it, but yeah, we would like to watch the child. But I just sort of feel like they're not admitting the kid. And it's probably not going to pass in 2 or 3 hours. It's probably going to be 12 or 24 or longer.
Yeah, I mean, they might do serial X-rays. That is something that they do, and it just to like sort of mark the passage of the light bulb. And so it probably is going to. I think it's a great idea to talk with them ahead of time and decide like if that's something that they think is reasonable, or if you have. I would just be very wary of not having a really clear follow-up plan for that child to go to GI clinic the next day or whatever. Like this is not a kid that I would want lost to the ether.
All right, so clearly this kid ate a light bulb. I'm getting a lot of pressure from my friends in the studio to make jokes like that was a great idea, but we're just gonna move on and turn to our mystery image. And if someone could advance to mystery image for me. So our mystery image of the evening, this is a person who feels like they got something in their eye. It's scratchy, it's irritated, and if someone can show that image, we stain it, fluorescein, look with the woods lamp, and you see this. Now this has a special holiday themed sign. If anyone can, the first person who can name the correct sign that this is in the correct holiday theme in the YouTube chat wins a prize, AirPods. Answer now, we'll review at the end. All right, time to move on to our next segment, Procedure of the Month with Sean Nort and Paul Hanna.
You can put them on. Okay. You're on. Right. Hey, everybody. Welcome to our holiday December wound care, or what are we doing? Urgent care? Procedure. Hey, we're going to talk about a case that many of you have seen, but we want to just make sure everybody's familiar. So, Paul, I'm going to give you a case. You have a 20-year-old who's coming in, bleeding from the nose. They bleed about 30, 40 minutes. Tried it at home, holding, and they come in. What's the first thing you're going to do?
So, first things first, we need to have him more comfortable. We'll get him in a chair, get a little kidney bassinet, and have them put some direct pressure, tilting their head forward, not backward. And then we'll go ahead and get some things set up so we can take a look and see what's going on.
So remember, a lot of these patients, they are stressed out a little bit, and they have clot. They might be spitting it out, coughing it up. So that's where the kidney basin is good. Protect yourselves, though. Ideally, wear some face protection and a gown because they might sneeze or even cough up some clot on you. Okay, he's holding pressure. You take a look. It's still bleeding. What's your next steps?
So we'll have him blow a little bit of, blow their nose gently to try to get a little bit of the clots out. And then we'll take a look, squirt in some phenylephrine in there, and try to see if we can continue to hold some pressure as well.
Yeah, so I think that's good. So phenylephrine, that's what my preference is. Oxymetazoline, but a nasal spray that is a vasoconstrictor. And then we're going to use one of these devices. So this is a commercially available device. At your urgent care, you have these.
We do have one of those.
All right. What if you don't have it? Well, there's a quick and dirty thing we can do. You take 2 tongue blades, okay, and you get some tape. And as you tape them up, you can make, and this is how I do it. I just do this real quick, right? And I tell them you're going to look like Pinocchio a little bit. And you get this, and you just have them put it right on their nose. And actually, a lot of people actually think these work better. So you have them do that because no one can really hold their hands for 15 or 20 minutes. We do that, and they're still bleeding. Is there another medication we can try, Paul?
Well, if we can visualize where the bleed is coming from, then we can use some silver nitrate. You just got to be very careful. Don't leave it on for too long. It's kind of a touch and turn kind of situation there.
Yeah, so what Paul's mentioning is Kisselbeck's plexus. If you're in the UK, other parts of the world, you might know it as Little's area. But remember, anterior epistaxis usually comes from that small plexus right in the front part of it. So yes, you can use silver nitrate. And remember, as Paul said, it's going to burn, so you don't want to leave it in contact too long because you can actually burn through the septum, but it's just a rolling thing. But we can also use tranexamic acid, or TXA. You use TXA?
I do. In some of my shops, we use some TXA as well.
So how do you use it?
You can either use one of those little packing cotton balls, or you can use a 2x2 where you'll roll it and you'll dip it into the TXA and you'll go ahead and insert it into the nose.
So this is very safe. You can use about 5 or 10 mils, that's 500 milligrams to 1,000 milligrams of the injectable. You just soak it in there like Paul said. You can either use, as he said, commercially available, or you can use the, you roll it up sort of like a cigar. Now I'm gonna put on my gloves just so I'm all nice and official here. There's a couple other things that I wanna show people. One is a nasal speculum. You really do need to have a good view in there. And the other one that maybe people don't have, but it's a good thing to ask and make sure you have at your urgent care, is a bayonet forceps, because even when we're doing that TXA, when we're putting this in, it gives you nice control. Visualization, you want good light, you can use the nasal speculum, right, to open them up, and then you go in there. All right, Paul, now we look, and he's still bleeding. Where are we at?
So the other thing that I would do is I would start with going with a packing. We have some commercially available packings at the urgent care I work at, and so you can either soak it in TXA, or you can put a little bit of numbing medication on it and go ahead and insert it. The most important thing is you want to make sure you're inserting it more inwards, not upwards. You don't want to go into their brain.
So I believe we do have an image there that will show you, but this one actually contains Miracell, and this expands to about 2 to 4 times. So you put it in, as Paul was saying, straight back, no lobotomies, right? We're not going through the cribriform plate, straight back, and then once it's in there, you can put a saline flush, 10 mils, and that'll help expand it. And this goes quite a bit. And then this string is there, and you can just tape it to the side. There's the other ones that have a balloon. To make it more comfortable, you can use some lidocaine jelly. It lubricates, and then because these can be uncomfortable. So now we have it in there, okay? We have control, we think, whichever one we use, will we use this or the balloon device? Do you put them on antibiotics?
I normally do. I work at a standalone urgent care, so I don't really have the setup to get them set up with ENT. So I don't know when their follow-up will be, so I usually do.
So of course, the chat's probably lively like it always is, and people say, are they really necessary? Well, the guidelines are if it's over 24 to 48 hours, probably. Who knows if it really is necessary, but if there is going to be packing and there may be a delay, and as you see in the image there, we'll go straight back with that commercial packing. I generally do it too because so many patients may not, even if you have good follow-up, may not be able to follow up. So what antibiotics do you use?
I usually do amoxicillin carbonate.
Yeah, so you can use amoxicillin clavulanate. You can even use plain amoxicillin. If someone has a true allergy to penicillin, then doxycycline is a really good choice. All right, so finally, Paul, right? We look in and the person says, I still feel I have something. We look in the back of their mouth, there's still blood dripping. That could be a posterior, which is an ENT emergency. So that is the further part of the nasopharynx from the sphenopalatine artery. Pretty uncommon, but that person needs to be referred to the ED. The vast majority of these, more than 90, probably 8%, will be able to get controlled in your urgent care, and you send them there. So thank you for being here, Paul. I just want to remind you, we have a great chapter and great videos in Corpendium and EMRAP. So if you're a subscriber, check that out. Next, I spy Mel Herbert's funky eye in a video, and then we're going just over down to Hollywood to the Mel Trebek studios for a little Jeoparty. Thanks, Paul, for being here.
Thanks for having me.
So I woke up this morning and this happened.
What the is that?
I know, terrifying, right? So what's your diagnosis? There was no trauma, visual acuity's fine, there's no pain, maybe a little bit of irritation, but certainly no pain, no ocular pain with movement or with light. That's right, It's a spontaneous subconjunctival hemorrhage. So what's the deal with this? Well, the key is that, as long as there's acuity is fine, there's no trauma, there's no other systemic sort of inflammatory syndrome or bleeding disorder, these resolve spontaneously. There's a familial sort of distribution. Every bald white man in my family has these. And they just get better over time. They turn sort of brown and then, yellow, and then they go away. There is sort of an association possibly with hypertension and diabetes, but it is tenuous at best. The vast majority of people don't have any of those things. So you might want to check their blood pressure and check their glucose, maybe. But these just occur probably spontaneously, or maybe just with minor trauma that they don't even remember, maybe contact lenses, or they rub their eye and this happened. But the key thing is that people are terrified that this could be sort of a stroke preamble, but it's not. It's all about the reassurance. And if you want to read about this in one of the most excellent chapters you've ever seen, check out Compendium by these people. That's right. It's outstanding. Rub it out.
All right. Ready for some Jeopardy? Let's do it. So I've created some questions. There's some good themes here. Santa and his big belly. Jingle bones. Put a little holiday in your heart, and 'tis the season medical trivia. I think since Armand is our guest on the show, we're going to let you go first.
Thank
what
you
would
so
you like
much.
to tackle?
All right, Britt, let's do Put a Little Holiday in Your Heart for 100.
All right. So this EKG comes with a story of a person coming in with syncope. Mel Herbert.
PE. What is PE? What is Alex Trebek?
You don't get more points for accent in
None
this
of
game.
those are the answer.
Okay.
Dr. Kovner.
I haven't counted the boxes. I'm going to say long QT because it's slow and it looks like it's not more than the RR interval, but it's not a PE.
And you would be right. Prolonged QT syncope.
But what about the flip T waves in the anterior leads? Come on, that could be a PD. That could be right heartstring. Come on. Alex, you're full of it.
I'm sorry, that wasn't the right answer. Moving on. So, Scott Kovner, which would you like to tackle next?
I'm going to go with Santa and his big belly.
All right.
Judgment call.
For how many points?
We'll do 100.
100.
Yeah, we'll do 100.
All right. Most common location for an anal fissure. Ooh, yes, Dr. Herbert.
The anus.
Okay.
How about more specifically? Dr. Kovner.
I'm going to go posterior midline, and I want to know, that doesn't seem close to the belly. Santa's got a really big belly or really big problems.
It's GI topics. Okay, and you are right. Posterior midline. The point here is if you see a fissure that is not posterior midline, think about some of the more concerning things: IBD, cancer, HIV, tuberculosis. All right, Scott, the board is yours.
Let's do 'tis the season trivia.
For
100. We're going to keep
100.
it simple.
All right, this is the question. What is the answer? Yes, Armand.
I'm going to say pityriasis rosé.
Whoop whoop. Also known as Christmas tree pattern.
Christmas Harold Patch.
With a Christmas tree pattern. All right, so yes, that is the answer. That is correct, Christmas tree pattern, and you have the board.
Sure, let's do Jingle Bones for 100.
Jingle bones. All right, and also I encourage the watchers, the listeners, YouTube chat, put in some answers. Yes, Scott.
I'm going to say that's a mallet finger or a gang sign.
It's a mallet finger.
Okay, all right, cool.
For some extra credit, what is a mallet finger? What happens?
I'm not that good about ortho, Britt.
It's a rupture of the extensor slip, and I would put this in extension. Alex!
Yes. So it is held in flexion, which means the extensor tendon is injured at the DIP joint. All right, so I give you that. Mallet finger. What do you want?
Let's do Santa and his big belly, work our way up the elementary track, 200.
All right. So this hernia can be reduced, but arterial blood flow is not compromised. Scott?
What is incarcerated hernia?
Boom. And if arterial blood supply was affected, it would be?
A surgeon's problem.
And a strangulated hernia. All right. Scott, you are crushing it.
All right. Jingle bones for 200. Let's do it.
All right, another finger in the opposite direction.
What?
No, you can't flip off the audience. Stop it. But yes,
That's what I thought when I saw
that
that
is.
picture too. That's what I thought.
That is
I was like,
also-
wait, can we play this on YouTube? Is this allowed
That
on
is
YouTube?
the ring finger, everyone.
Yep.
That is
Oh, got
the
it.
fourth digit, to be clear.
In some cultures, that's the same thing.
All right, y'all are pausing. What's the answer? What's the answer?
This is a Jersey finger, I think.
All right, yes, this is a Jersey finger, and because it's held in extension, the flexor tendon is injured at the DIP joint. Again, all right.
And then it's like this. You're like grabbing the football player as they run away
Exactly.
and pops it off. Bing.
Just like that. All right,
I didn't know that because I'm not athletic. That's
right.
and Mel plays so much football.
I'm an Australian football player, mate. I mean, look how tall I am, for example. Like,
All right.
I'm huge. Check out how big I am.
We gave him a stool.
This is absolutely unfair. I'm just saying.
We all complained about this
Yeah.
before the segment, just so you know out there.
All right, Scott,
All right, what do you guys want to do?
let's get challenging.
Let's do-
move to the
Do like a 400
400s.
one.
A 400. All right, what do you
Yeah.
guys want to do? 400. Let's do holiday heart 400. Put a little holiday in your heart.
All right. This person also comes in with syncope. And the answer is Armand.
I want to say Brugada.
You want to?
You wanna?
And you would be
I'm
right.
sorry.
You
What is
definitely want
Brugada?
to. All right, and
Which type? 1, 2, or 3?
Okay, so it's definitely one of those, yeah.
Type 1.
type 1.
Type 1, all right.
Highest risk one.
It's like Saddleback?
Yeah.
Yes,
Yeah.
and
I was
so
on
with
Moore Cove, Saddleback 2. Saddleback
exactly
2.
with Brugada, we see basically an incomplete right bundle branch block. We're going to see this in V1 through V3. Sometimes it can extend to V4, and then you're going to see that coved ST elevation. With type 2, it's more of the saddleback. Type 3 is just not as much as ST elevation and still a little bit saddleback. Hard to tell. Okay, so Armand, the board is yours.
Cool. Let's do 400. Let's do Jingle Bones for 400.
All right. Patient has neck pain after shoveling snow. Scott Kovner.
Clay shoveler's fracture.
It is.
Snow shoveler's
it's
fracture.
Snow.
You know, hey, listen. You're
Right, and this is
listening
one
out
of
there.
those, I want to point out, this is one of those cervical fractures that's actually stable. It's a fracture of the spinous process, usually the lower spinous processes. And it's, yeah, the clay, the heavy snow, something that gets some tension on the spinous process and causes a fracture. All right, Dr. Kovner.
This is why I don't do manual labor anymore.
That's why we live in LA. All right, let's
No,
do Tis the Season Trivia 400.
Okay, 'tis the season. Hemophilia B, also known as Armand.
What is Christmas disease?
Woo!
Damn,
Yes,
damn,
Christmas
damn, damn.
disease.
I thought that was Hanukkah disease.
And who was Christmas?
Huh?
Who was Christmas?
Oh, who is it named after?
Yeah, who was it
Great
named after?
question. I actually know the
Christmas,
answer.
Obviously.
The first patient
Yeah,
that
the
ever
kid's
had
name
this.
was Christmas.
His name was Christmas. Sickest patient I ever had. Hemophilia
Stephen
patient.
Christmas? You said Christmas? Damn.
Okay, so that was Armand. Board is yours.
All right, let's do Jingle. Oh, nope, sorry. We're going to do another 400. Clear out the 400. Santa and his big belly for 400.
All right, hypochloremic, hypokalemic, metabolic alkalosis. What pathology? Dr. Kovner.
It's going to be a lot of things where you vomit a lot. But if it's your belly, I'm going to say pyloric stenosis.
We're in the belly, we're in a baby belly, pyloric
All right.
stenosis. Yes, and you're right, you can get a lot of this from just a bunch of vomiting, but that is the classic kind of three things we think about on labs. The test answer is always going to be pyloric stenosis.
Santa's not a baby, though, despite that song.
You know, I was just I was just trying to get clever with some names,
That's
okay?
right, that's good.
All right, which ones do we have
moved up
left?
from the tear, you know?
Kovner.
I don't know, what do you guys want to do?
We moved up from the
I can't
tear.
tell the difference between the colors, so I think
Yeah,
that this
it's-
is like I've
purple
got-
ones.
The
I think
purples
the
are the ones we have not done.
Let's do Big Belly 300. Let's go for it. Let's close out the column there.
Big Belly 300. This infection causes diarrhea that is pale, loose, floating, and foul smelling.
That was my nickname in high school.
Maybe this person
Pale,
went
fatty, and
camping
offensive.
recently. Armand.
What is giardiosis?
Giardia. Yes, you are right. This is the most common parasitic diarrhea worldwide. Usually it's from water contaminated with feces. Disgusting. And metronidazole is kind of the go-to treatment
And
for
when
this.
you belch, it smells like farts.
It smells bad. I mean, I've never had it, but I hear it's pretty bad.
One of the clinical criteria.
Bad burps. All right, so who got that? Armand.
That was me. Let's do Jingle Bones for 300.
Question.
Well, this is gonna make me.
It's a guy's name.
Armand.
This is a, Galeazzi Montija. What is Smith's?
It is Smith's fracture.
I knew it the first time.
Smith's fracture is just a reverse collie. So instead of having, let's go back to the picture. Instead of having this piece of bone dorsal, it's ventral. It's really just a distal radius fracture. Reverse collies treat.
That makes no sense to me because if you spell collies backwards, it's not Smith's.
No,
Right?
it's not. It's not.
Just
It's
saying. Go on.
But if you don't have to remember both names, if you just say reverse collies.
You know,
pretty good.
it's always a pleasure working with these boys. Let's move on to the next question, shall we? Armand, we're going to give that to you.
Sure.
Purple is what we have left.
All right, let's do Put a Little Holiday in Your Heart for 300.
Put a little holiday in your heart. This person also comes with syncope.
Of course.
Scott Kovner.
Look at that. Look at that beautiful delta wave. Look at that
It's
WPW.
so pretty.
Looks beautiful.
All right, I want to point that out to the audience just so we can see. These are the delta waves. It's the up-slurring of the early QRS complex, which leads to a shortened PR interval, which in and of itself, we don't really care about. But if you get stuck in an antidromic or orthodromic re-entry circuit, you have syncope and maybe death. So this is WPW. Very important EKG
I
to
feel like
know.
I see these all. You're like, oh, it looks so cool. It looks like a delta wave, and then cardiologist's like, nah.
Not
Like,
excited.
all the time. Yeah.
Okay, Scott, you got the word.
Let's do the holiday heart one again. Whatever we got up on that. We're at 200.
Oh, hold on, we got to go back to the board. I'm going to stop touching it.
Don't touch it.
No, okay, which one you
All
got?
right. Let's do 200.
200 holiday heart.
200.
This person also comes
Has
in
syncope.
with syncope.
Whatever.
They're a young male. Armand.
What is Hokum?
Boom. This is hypertrophic cardiomyopathy. Looking at this EKG, I think the easiest thing, so you see an LVH pattern, which you shouldn't see LVH in a normal, healthy young guy. Also, you get these dagger Q waves, and you see them in the inferior leads as well. So those are your dagger Qs, LVH, really narrow QRS. That is Hokum. All right, Armand, let's finish it off.
Shall we? 'Tis the Season Trivia, 300.
I love this question. Compression of the left renal vein between the aorta and the mesenteric artery.
What is Nutcracker Syndrome?
Boom! Nutcracker syndrome. I love this. From the urgent
You're
care.
thinking of another nutcracker, yeah?
That's not the nutcracker I was thinking of, mate. You know what I mean?
Taking it back to medical education. Nutcracker syndrome. This is actually a really, really hard diagnosis to make and can go missed for a very long time. This might be somebody with vague flank pain that you think maybe is a stone. You check urine and you might even see some reds in the urine, but the story is just not that like sharp, radiating pain. Put an ultrasound on there. You'll see hydro. But again, it's not from a stone. It's from compression of the renal vein. So very cool diagnosis. Very cool name, Christmas themed. All right, so Armand, finish us off. Last question. 'Tis the season. What is this? Scott Kovner.
Christmas tree adapters.
It even looks like a little Christmas tree.
Also sometimes called conifer adapters, you know, if you're a nerd like me.
Wow.
That was a great joke.
All right, yes, this
that
is
one landed
Christmas
with
tree.
the online audience.
Okay, the score. Oh, we have a tie. Mel, you're not even in the running.
I'd like to thank my little box here for helping me.
Okay, then how about final question? This is, you're going to write it on your board. You're going to put out a number of points you're willing to risk here. Ready for your question? Mm-hmm. All right. We got to keep it holiday themed. Santa, he's coming to visit some kids. He gets stuck in the chimney. He comes into your emergency
Nutcracker
room
syndrome, sorry.
and he's having some headache, some nausea. What toxicity does Santa most likely have? Do, 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 do. You can't talk to each other.
It's fine. I'm repping the East Coast.
All right, you guys are out. What is it?
He was asking for a spelling question.
I just had a spelling issue.
He's
What is
betting,
it?
He's betting negative 100. You know, we're.
Okay, so Armand, what did you say?
I said carbon monoxide poisoning, and I'm betting the rest of my apple juice
Nice.
and the 2,000 points.
And Scott?
Said
Sounds
CO
like you
poisoning.
agree.
Yeah.
Mel, I'm terrified to see what you wrote.
I had vodka for minus 100.
That also could be correct. I don't know.
Store it in the chimney.
All right, it
And I
sounds
couldn't
like
spell vodka, which is a real issue.
that's what you couldn't spell. Okay, we got to move on. All right, so we got to tie Scott, Armand. Thanks for participating and making it through that game. Mel, you're out. All right, next up we have our
Stupid game anyway.
next up we have our final segment. We're going to move into Paper of the Month, a year in review. All right, guys, welcome to it's really Papers of the Month, a year in review. Now, these papers all come from the Journal of Urgent Care Medicine, and they're all chosen by our wonderful, beloved Dr. Josh Russell. Okay, so first paper, we're going to present from in here, and then the faculty in the main are going to kind of dissect the paper, give us their opinions, thoughts, is it practice changing? First paper we're going to talk about is validation of the PCR strep test in the urgent care. So essentially, when we go to diagnose strep throat, we've got a couple things, right? We've got Centaur criteria that we can use. To be honest, not great. We've got a rapid antigen detection test, which is better. It's okay. It has a sensitivity of about 86%. But that's not good enough. And really, the guidelines tell us that we should be confirming a positive rapid with a throat culture. Now, what this paper is actually looking at is a PCR. It's a rapid PCR done in real time in the urgent care to see really, is this as good as a throat culture? So it's a validation study, and it's looking at a worldwide validation. It's really just looking at Washington State. And essentially in this study, there's about 250 patients. All of these patients had to have both a PCR as well as a culture. And what they found is the PCR did pretty great. The PCR, when compared to the culture was used as our gold standard, had a 99% sensitivity. Like, PCR turned out to be really good. Now, there's another part of this study looking at just those that got throat culture. That was about 380. Now, I think the interesting thing here is we all know throat cultures take about 1 or 2 days to come back. About 46% of the time, providers would give an empiric dose of antibiotics. Start patients on antibiotics empirically while waiting for the throat culture. The interesting twist there is that only about 17% of the time were those patients called back when the throat culture was negative to stop the antibiotics. And the vast majority of these cultures ended up being negative. So, the paper really says PCR looks like it does pretty good. When it comes to throat cultures, it looks like we're probably still overprescribing antibiotics for sore throats. I'd really love to hear what the rest of the faculty has to say, so throwing it to you, Scott.
Yeah, thanks, Britt. I mean, where I work, we don't have any PCR testing for Group A strep, and I think it's also important to point out in the paper that this specific PCR assay only looked at Group A strep. So you might, some places work where your culture data might give you some other, different bacteria or other information that you wouldn't get. But do any of you guys work in a place that, Paul, were you saying you don't have that where you're at?
We don't have the PCR. We do have the rapids, but not the PCR ones.
Gotcha. Yeah, have you guys worked in a place that has any PCR available?
Not that I have the PCR, but I think from a clinical standpoint, if you're worried about it, I mean, we won't get into the debate whether they're even indicated, right? That's a whole nother show. But If it's positive and you say you're going to treat, but if it's not, I do not routinely get throat cultures in these patients. It's really not going to change anything. And usually I have a once I examine them, my probability of whether I think that it's going to be a group A strep infection or not, just from my clinical gestalt.
I know, Mel, you did a piece on our UC Fundamentals series on sore throat. You went into a little bit about the Centaur criteria and how pretty much it's a coin flip, right? When you get your greater than 4 score, you're at like 50% or something like that?
Yeah, but that's not bad. The problem with these kind of studies is that we don't really have a great gold standard. Culture is a terrible gold standard. It misses lots of people. It's positive in people who are just carrying it and they don't have the disease. PCR we know is pretty good. But I think a lot of people do what Sean does. It's like, if this really looks like strep, I'll just treat it. I don't need any cultures for exactly this reason. Who's going to follow it up? You're an ER doc, you're gone, you're in Malibu, you're smoking cigarettes, you're drinking vodka, you're surfing, it's 2 days later, the culture comes back, nobody's checking that. So if nobody's going to follow it up, why do it? It's very expensive and that cost goes to the patient. So treat or not treat. And there's an argument for not treating most people because they just get better. The post sort of infectious complications of strep basically disappeared before penicillin got here. There is still some communities where this is a problem, so don't worry too much about whether you're going to miss a strip. The vast majority of people get better and have no complications, but I do it Sean's way. If it looks big and pussy and painful and febrile, treat it, and if it looks like they've got part of a viral syndrome, no tests, nothing, you're out of here.
Yeah, totally. I practice it in a similar way, and I think it's funny you mentioned that, like, you're out in Malibu smoking cigarettes, whatever. In the study itself, the people that were prescribed antibiotics and they had cultures obtained, there was no change in the antibiotic practice after the cultures were negative. So clearly nobody's looking at these things, and whether you practice in the urgent care, maybe you're seeing these patients in a primary care office or in an emergency department, you're probably not going to follow up on that because it's such a low-hanging fruit. And I think you make another really great point. The rheumatologic complications of group A strep were much more feared 40, 50 years ago. And today we just don't really see that problem with the epitopes that are on the proteins, the M proteins on them today. So do we even need to treat? I don't know, not something that I keeps me up at night anymore. In the study, there was also not a lot of children that were in this group, which is something that I kind of understand. I guess most of them probably have access to a pediatrician, or maybe they're getting their care somewhere else from somebody else. But I find that's really where I'm in this diagnostic quandary most of the time, because for adults, it's just I don't know, a sore throat, you'll be fine, kind of thing. Yeah. Any other thoughts on the paper?
It was printed on beautiful texture. Was the font, like the font a lot.
Like the
highlighting, excellent.
Really good Helvetica. Well, the other thing just to note about it for those who go and read it in the Journal of Urgent Care, it's sort of retrospective, and the sensitivity that they reported, it's important because if you haven't had access to a PCR test before, you're looking at literature that compares this to some gold standard stuff. There isn't a great RCT that's out there. It helps to at least hold the manufacturer responsible. The original sensitivity specificity data of 98%. This study approaches that specificity, but they're only looking 6 or 7 samples for this. Remember, a retrospective study in this way isn't the best way to derive the sensitivity and specificity data set. So a little bit of a grain of salt. It doesn't change my practice, but I'm very comfortable using PCR, knowing what the asset is. And if I had that available, I'd definitely do that over a culture like you were saying.
Oh, I would agree. I would agree entirely.
All right, that's our opinion here, Britt. What do you got for us next?
Okay, next paper, the second of 4 total. So the second paper is looking at conquering the fear of the penicillin allergy, also known as the boogeyman of urgent care. This is actually written by our very own Josh Russell, and it's an editorial piece, kind of an opinion piece on how we approach people with penicillin allergies in urgent care. I want to just share a couple facts. 10% of Americans say that they have a penicillin allergy. However, when we look in the literature, the research that has been done on this to see what people actually have a true IgE-mediated allergy, that is only about 1 in 10 that have a true allergy to penicillin. So I think that really brings to light that this is probably a bit over-reported. And Josh brings up a good point in the paper that, urgent care visits are quick. It's a quick turnover. You're seeing kind of low acuity stuff. You might not always have time to go through everybody's medication and allergies. But when it comes to prescribing antibiotics and really practicing good antibiotic stewardship, it's probably a good idea to sit down with some of those people who have reported a penicillin allergy that you'd like to prescribe a penicillin to. Maybe what were their allergic reaction symptoms. If it's nausea and diarrhea, well, that's probably just because they took antibiotics and it's not really a true allergy. One of the things that you can also do to kind of assess whether or not this person is going to likely have an allergy to penicillin is using PenFast. This is brought up. This is actually a clinical decision-making rule. It's 3 questions, super simple. Basically asking, did you have an allergic reaction in the last 5 years? If you had an allergic reaction, was it anaphylaxis, angioedema? And did you require any treatment for the reaction, like did you need epi? If you answer no to these questions, then you have a really low probability of having a penicillin allergy. And if yes to some of these, your probability becomes higher. So that might be one of the ways that you can assess whether or not you think it's safe to give somebody penicillin. Again, would love to hear the thoughts from the group. So Scott, take it away.
Yeah, I mean, I feel like I'm pretty cavalier when patients come in with a penicillin. I'm an advocate that there should be, we have all these like 2 clinician consents for doing different things. Like there should be a 2 clinician consent for putting an allergy in the chart, because sometimes we get a little like carried away. Like I had a weird sneeze when I took an antibiotic 25 years ago. Oh, we better put that in there. And then you get all the EMR boxes, right? So I'd love to hear your guys' practice. For me, I lean very heavily into like your 99% chance that you're not actually allergic to this after talking to the patient, hearing their story, knowing the overall statistics. I haven't used the PenFast tool. I just kind of risk stratify by realizing, hey, when you were 5 and you had a viral exanthem that someone gave you penicillin for, it probably doesn't mean you're allergic to it. But Sean, how do you feel about this, obviously?
So I think that there's some clinicians that, because the question really is, can I use a cephalosporin? That is usually by far. So don't let a septic person die if you were in that setting. But this is the urgent care. We're not dealing with septic people. So some people say it's not true. That is not correct. But then some people overstate it, right? You might get a call from a pharmacist, and I'm a pharmacist, right? Yep. And they'll say to re-prescribe or use something else. I will say, if you look at first-generation cephalosporins, the incidence or cross-reactivity, if they have a true penicillin allergy, might be as high as 7%. As you go to second generation, it's less. And when you go to third generation, it's actually quite low. But people that are allergic to a lot of medications are allergic to a lot of medications. Those are atopic people. So if they have a list of 17 different antibiotics, at least take a good history. What I do, though, because most of them I agree, hey, I've been told since I was a kid, right? Yeah. My mom always said, I give them the first dose in the urgent care and I watch them. And you don't have to watch them for hours and hours, because within 20 or 30 minutes, if they're not having a severe allergic reaction, you should feel pretty comfortable that you can discharge them. And if there's ever a question, that's what I do.
Yeah, I totally agree with you. The definitive, by far best study that ever did look at this was by Herbert et al., Canadian Journal of Emergency Medicine, 2006. It was outstanding, I'm just saying. But when we reviewed this literature, and that was a long time ago, we found the same thing. And the point that I really want to make up is that person who says, I'm allergic to penicillin, and I'm allergic to erythromycin, and I'm allergic to phenytoin, and those people, there is a group that it's like that. And we found when we reviewed the literature, there was really no cross-reactivity between cephalosporins and penicillin. When you excluded all of those, the fact that most people don't have a penicillin allergy and stuff, but if they really had a penicillin allergy, there's a really good chance that they will be allergic to water. They're just a group of people that are at high risk. So no matter what you give them, you should probably do it in the urgent care while you watch them for a while, no matter what drug it is. Because although the chance is still low, it's much higher than the rest of the population that they'll be allergic to an antibiotic that has no structural similarity to the penicillin that they're allergic to.
And I find it's one of those things that like the 2 extremes of that can present the same way, because you get the person with like the 45 allergies, you're like, oh, you're allergic to everything. Yeah. And then it's also like, oh, you're allergic to everything.
That's right. That's right.
So you just have to really spend that time to figure that out.
I'm allergic to Haldol, I'm allergic to droperidol, I'm allergic to olanzapine, I'm allergic. I know what I'm talking about.
Yeah, I think the thing that's always at least really helpful in my practice is if you have access in your EMR to look up the previous medications the person was prescribed, because if you don't have the time maybe to do the sit and wait test, if you saw they just I had a patient one time like, I'm allergic to penicillin, but that PenVK stuff I was fine with. So we're like, okay, cool. Like we're probably okay. We can educate a little bit more. But I think that's all the thoughts we have here. Anything else that you do differently, Paul, with your
No, I think I try to talk to them about if you think you're allergic to penicillin and I don't have the resources to like give them the medication, or I can't really look in their charts because it's a standalone urgent care, then I'll try to shy away from it. But I encourage the patient, like, talk to your doctor. Let's actually get tested make sure you're allergic or not.
Yeah.
That's one of the things I talk to the patients about.
I think it's a great point too on the education at the end. It's like if you've given them the test dose and it worked out, to like let them know that it's okay so that they don't continue propagating an allergy in their own chart and other standalone centers. Cool. Well, that's all we got for this paper. I think let's throw it back to you guys.
All right, guys. So this next paper is on my favorite presentation for a patient, which is dizziness. This is sarcasm. And so this is actually a case presentation. So this is about an 86-year-old guy who comes into the urgent care. He wakes up, he all of a sudden feels like he has this sensation of imbalance. And that's been constant since he woke up. It doesn't matter where he moves his head. It doesn't matter really what he does. He's continuously having this imbalance feeling. And he also feels like he's having this vague confusion symptoms along with it. We don't really have to go too much into the case. He eventually ends up going to the ED, getting a CTA, and he has a cervical artery dissection. The meat and potatoes of this paper actually are really about your approach to dizziness. So here I've got dizziness, right, vertigo, and we can kind of break this into two groups, right? So we've got the peripheral causes, and we can think of those as like benign paroxysmal peripheral vertigo. I can't believe I got all that out in one sentence. Then we've got vestibular neuritis, things like labyrinthitis, and then Meniere's disease. And then the way more scary things on the other side, right, in the central causes of vertigo and dizziness. We're talking things like a stroke or a TIA, and we'll loop in the dissection in here. Other things that can cause this are a mass as well. So I wanted to kind of throw this over to you guys. What do you think about this approach to dizziness?
Yeah, definitely. I mean, I think dizziness can be certainly one of the most challenging presentations. Even if you have like an MRI, CT available at your fingertips in the urgent care, it can be even more challenging because when you have less resources, you have to know how to do more with what you're having available to you, right?
Absolutely.
Stuart, I know you look, Mel, you look quite different.
I was going to, isn't anyone asked what happened to Mel? He suddenly became a lot more handsome. He's more handsome and he has much more prominent EJs. I don't know, but that's, yes. So, yeah, let's talk about it for a second. And we'll sort of work the case in. But basically, when you're talking about dizziness, you've got your group of people that are lightheaded or they have a pre-syncopal episode. That's sort of one category. Those are patients that, and you can pick this apart usually by history. You're thinking about VTAC, you're thinking about maybe, this gentleman was on a couple of meds. If it was just when he got up, for example, if it was just, postural, you might think about that. Otherwise, you might be worried about VTAC, you're talking about EKGs. But that's not usually the dilemma. Usually what we're talking about is patients who are having the sensation of movement, the actual vertigo. And the thing about that is that we're worried about stroke. I mean, that's basically the bottom line. And in this case, this is what it is, right? It's a dissection, which is one of the causes of stroke. You get a dissection, you get a clot there, and you get a stroke from that. And so that's the big thing that we're all worried about. Now, just a couple of points about that. First off, one big pitfall is that we're always taught sudden onset is vascular, right? Doesn't help that much when it comes to vertigo because benign positional paroxysmal vertigo, there you go. That one, just based on my clinical practice, they often tell you, I woke up and it was suddenly, it does occur suddenly. So, especially if that was a bit of a younger person, that doesn't really, get me too exercised. But when it comes to, vertigo, your most important thing, and I'm thinking back to all the med legal, I used to do some med legal defenses of these. The number one thing that you find, the pitfall that people don't do, is they don't make sure that it's isolated, because the vast majority of strokes or TIAs or stroke syndromes, that's not isolated vertigo. That's vertigo that comes with something else. And so when you do that careful exam that involves the cranial nerves and making them walk, right? You get I don't know, you guys heard about the 5 Ds, right? Mm-hmm. So there's the dizziness, which is the vertigo, and then there's the diplopia, so your eyes, and then there's the dysarthria, right? You can evaluate that, how they're speaking, the dysphagia, and then the dysmetria. Did I get one of those wrong? I think, I always make up and subtract a D every once in a while. But anyway, so yeah, that's why it's so important to get that gate, because you want to make sure you do that cerebellar testing. It's honestly, most of the cases where there's something missed, they didn't make sure that it was isolated. And when it's isolated, it's not usually serious. Now, having said all that, this guy is 86 years old? And so even then, maybe 8% or 10% of the isolated vertigos, unfortunately, do turn out to be strokes. So I would say, to be honest, in an urgent care situation, this guy comes in, and this is a new thing. You know what? That's going to kind of trump everything else. I'm going to, he's too old. Now you might be thinking there's been so much buzz about this HINTS test lately. The head impulse test, and you're looking at their eyes moving, and it's supposed to be very good for distinguishing, and it is in papers written by people that do this for a living. By neurologists and by the experts in this field. I would not hang. This is a really important point. I would not hang my hat on that in a situation where there's a new onset and it's an 86-year-old person. And the last thing I would say about this is that, and this is really the clincher, it makes everything else that I've said irrelevant, to be honest, is that he said that he was confused. I mean, which is, lucky, because usually it's got to be like a relative that says, he's not really, it's usually people don't volunteer that themselves, right? They're kind of, they're self-conscious about it. But if someone is confused, if there's any problem with thinking, remember, that means cortex. So all the other stuff is not relevant. We know it's central. We're really concerned. And so the confusion alone sort of kind of trumps everything else. And that patient's got to go and got to get worked up in the ED. So that's sort of my take on that.
Yeah, I think that's a really awesome one, obviously, Stuart. And I think it's tough because when you don't have in the emergency department, right? Like if you want to, you're hedging with the HINTS exam, you have the other tests that you can do to kind of hedge. You have a neurologist there, you can get an MRI, whatever. I know there's a whole discussion we had about that. But I think you're right in making the decision about having that early disposition from just a few critical and key findings that suggest a central etiology here is probably the way I'd practice in the urgent care. I don't know if you guys would do anything differently, but you do see it's a different patient population, so you probably do see a higher degree. There's no studies I know epidemiologically speaking of what percentage of people who present with dizziness to an urgent care actually have true peripheral versus central, as we'll talk about on the next paper. I think we're going to talk about headaches a little bit, but it is a different patient population too.
Absolutely, and the vast majority of, if not almost all, are going to be peripheral, but that doesn't mean none are not peripheral. I agree with Stuart, particularly if there's a family member that you can get a history, because that confusion may be really subtle that you or me might not appreciate. And the other thing that I've noticed is I'll have people tell me, I think it's BPPV. And it is clearly not BPPV. It's for hours and hours. BPPV is, I wake up, I turn my head, I vomit, and then it goes away, but then I turn around and it happens again. Yeah. Usually what they're talking about is vestibular neuronitis, that is probably more common, but be careful calling things BPPV that are clearly not BPPV.
Well, fortunately, it's all in the name, right? It's paroxysmal and it's positional. And if it ain't that, it ain't that, right? And so, that's true. You can Dix Hallpike your way, and we kind of de-emphasize that a bit all you like, but if it's continuous, you're done. Yeah.
All right, let's throw back to the Lightroom for the last of the 4 papers.
All right, guys, as you can see, my handwriting got better in the last 5 minutes. This is definitely not Britt's handwriting. So for the last paper, like Scott mentioned, this one's about headache and the red flags that are kind of associated with those secondary headache presentations. So this is another case. This is a 65-year-old lady. She's had a month-long history of a headache, initially diagnosis of viral sinusitis, and then for the last 3 days, she says, that those medications they gave me at urgent care, they're just not cutting it anymore. In fact, I feel like I have the worst headache of my life. I feel like every time I move around, the headache gets worse, and it's just not the same pattern as it was previously. And so this paper in particular is talking about a mnemonic called the SNOOP10 mnemonic, or SNOOP P10 mnemonic, and it's SNNOO and then 10 Ps. What this patient ends up having is a subdural hemorrhage after she goes and gets evaluated at the urgent care, and that's because they sent her over to the ED because she's got a couple of criteria on here that match with the SNOOP10. So she's older, she's 65, the pattern of her headache has changed, and her headache is now positional. So putting all those together, they decided to send her to the ED. She gets a CT scan and has a subdural hemorrhage. I kind of wanted to see what you guys thought about this whole mnemonic.
Yeah, I'm glad you spelled it out for us quite literally. I was pronouncing that as snip, the whole time. So I think it's really a tough situation. One of the best parts about the papers, they talk about that, like we were talking about, the difference in patients that present to an urgent care versus a primary care setting versus an emergency setting with headache. And they looked at primary care versus tertiary or emergency care setting, and it's almost 10 times as likely to have a secondary etiology of headache if you're presenting to an emergency care setting as opposed to a primary care one. So, it's a little bit maybe more of a needle in a haystack in a less acuity center, but still, again, you have less testing. So having a good sense of when you need to escalate is the way I kind of view this. Because we've all had those cases in the ED where the headache's kind of bad and you're like hedging a little bit. We'll just scan them. We'll take a look up there. And like when you don't have that luxury, it sort of changes things, right? I know, Stuart, what were you thinking about this case?
Well, I mean, she's got a lot of red flags.
Yeah.
Okay, she's 68, which last time I checked is older than 50 or 55, and that already takes you into a different category. So many of the primary benign headaches we see are in younger women, right? And it's primarily related to hormonal fluctuations, right? And so she's got that, and she's had the headache for the entire month, progressive, now getting worse. I mean, this is what you're thinking in a case like this, is that she's got a brain tumor that's now bleeding into itself. I mean, that's what you're thinking. Maybe it's metastatic, cancer. That would be sort of statistically what you'd be thinking. And so she's got a lot of red flags, and you're not really thinking about now. In days past, and I'm old enough to when CTs were a little bit tougher to get. You wouldn't necessarily even easily get one in the ED, but things have kind of changed, and pretty much everyone these days is going to think, she needs a CT now, because it's getting worse, and it sounds like it's something, it could be a mass, and you don't want her to go home and then wait, and then have, be found unconscious or in seizing, the next day and stuff like that. So I think it's really, she's got to go to the ED. Like you were saying, the vast majority of primary headaches, they're going to have a history of it. They're going to be younger. Now, I will make one. I think it's sort of a bugaboo of mine, which is that it's mentioned that she has the worst headache of her life. That is not helpful. Okay, and the reason is that most of the really, if you ask a patient who comes in with a severe migraine, to the emergency department, is this the worst headache of your life? You're like, yeah, it's really bad. I don't typically come to the ED. This is the worst. This is, that's a very common thing to say, and it doesn't really correlate with badness, and so it's kind of overemphasized. The key thing, remember, for really to be scared of when you hear patients say, is when the headache is not only really severe, but it's sudden in onset and maximal at onset, the so-called thunderclap. That's the real red flag here. So don't panic when you've got that patient that's got that history and it's like, yeah, doc, this is the worst. That's not the red flag. The red flag is all the other things that you listed here. Now, in terms of Snoop Dogg, I don't know if I'm hip with that mnemonic. I think it's great. I mean, I think it's great to have a list of things to go through, and especially when you're learning and these things don't jump out at you. I say absolutely, hooray, wonderful, and it's not some magic. It's just a list of the sort of the bad differential and thinking about it. But I would say that we've gotten a lot. There's certain headaches that we never used to catch. And some examples are, cerebral venous thrombosis, which is really, really serious thing. People it always used to be missed. Now when you miss it, you're kind of more on the hook for it because it's like, we've been teaching about this for a while. So that's one thing that's on the mnemonic that's important to think about. They got clotting risk factors, right? Another one is dissection, and that can be hard to pick up. But clearly, if they've got lancinating pain up the front or in the back, and maybe they've got a risk factor for vascular disease, you might think about that. Sometimes actually I remember some of the cases I've had of that were people either that came from manipulation, chiropractic, that's the red flag there, or people that are kind of like banging their head, with the old Iron Maiden tune, stuff like that. I saw like 2 cases like that, right?
That's awesome.
So anyway, those are some of the major points, I would say.
Yeah, that's great. And I think it's helpful to point out, too, that the Snoop Dogg mnemonic, as it were, the Snoop P10, isn't like a validated tool. It's just a mnemonic to help you remember it.
Yeah.
And like you said, perfect for learning.
Another one just actually that's kind of slipped my mind is another thing that we're kind of hip to that we didn't used to be, that you're kind of more on the hook for, is a woman who's either pregnant or postpartum. Because I remember all the time when you'd see women that were like, I don't feel well, my neck hurts and my head hurts, and it's, oh, you're holding the baby, it's new, it's obvious. We don't think that way anymore. pregnant women with a new headache, that's a red flag, right? You've got to, it could be, 4 weeks postpartum, you get preeclampsia, you can have that cerebral venous thrombosis and a couple of other things. And so that's another thing that it's kind of like more in our consciousness that's changed. So, yeah.
That's awesome. Thanks, Stu. I think we're going to throw it over to Brittany to join us now. Let's see if we're touching base with the rest of the audience. What else you got for us?
So much from the audience. I just have to make a quick plug for pregnant patients and postpartum patients. Up to 6 weeks. Up to 6 weeks. All those things that you can get when you're pregnant. Preeclampsia, the complications from clotting, 6 weeks postpartum, don't forget. Okay, so the chat was very active and the polling was very active. So there was a poll actually from Twitter about whether or not people treat strep throat just based off symptoms, a rapid antigen, or actually wait for the throat culture. I think from the discussion, everyone kind of falls in line. 7% of people wait for the culture, but 36% treat off of symptoms alone and 57% off of a rapid antigen detection test. Another thing that came up from the epistaxis segment, whether or not people use TXA, pretty exciting to see 75% of people use TXA. So that's cool. If you have it available in your urgent care, I highly recommend using it. Epistaxis is like one of my least favorite things. I feel like it's just the bleed that just never stops. It's a lot harder to manage in real life, and TXA can help quite a bit. I am really good at forgetting to announce the mystery image when we have one, so I'm going to make sure that I do that this time. Do you guys know what it was? It was that corneal kind of
It's a Canadian thing. It's a Canadian thing.
And it was
for sure.
Scratches like this.
Yeah, any Canadians that don't get this.
Disney on Ice?
All right, Stuart, what is it?
Well, I call it a hockey ring sign, but I guess it's not really
Yes.
it's an ice ring sign, but I like to
I've
say
always heard
hockey
hockey
ring.
too, yeah.
And Kara Buchanan was the first one to answer correctly. So, woo!
Yay!
Kara, you get a pair of AirPods, not iPods. All right, and a couple questions came up. The Brugada, Mel is not on mic anymore, but Brugada, the conversation of really thinking about type 1, type 2, type 3. Do you guys even care about type 2 and type 3?
I think you're right that you should care less as the numbers go up. I mean, the more that it looks like the thing that you learned that's on your boards or that's in your textbook, the more it's concerning.
Right.
The more that you have to say, oh yeah, that might be a type 3A, the less it's concerning. I think that's a general guideline.
Yeah, for sure. I mean, if you diagnose like a type 3 Brugada, it's like where do you finish your cardiology, electrophysiology fellowship? It's like pretty hard. Even the saddleback of 2, right? It can be so subtle. But 1 is like
one is the one
striking that
right.
code.
That's what you got to find.
Yeah. So 1, you really need to get this person admitted. They really need an ICD. 2, 3, cardiology follow-up, maybe some more provocative testing if you're really concerned, but those aren't people that necessarily have to get admitted.
I would mention that it helps to have syncope, or it helps to have an actual symptom, because especially if it's not really clear cut and it's just like they got it for an incidental reason. You can't go crazy. There's a lot of people that have a lot of patterns on ECGs, so that's what I've noticed is that people are like jumping up and down because they see something on an ECG and it's like, did the person have any symptoms? Is there any family history of sudden cardiac death? Well, then maybe you can just take a minute and contact their primary. And
I think clinical context is important, given that people get an EKG just stubbing their toe and walking into urgent care. I mean, we are very liberal about getting EKGs. So take that EKG into clinical context and really decide, is this type 1 and we need to be concerned, or 2, 3, cards follow up, I think, if anything.
Yeah, I just want to be clear. I personally don't know if the higher 2 or 3 type confers a higher risk of a deadly outcome. It's just it's hard to diagnose those. You still have a sodium channel apathy of some type, which I'm sure
I think it does.
Risk,
I think it's less likely to be of clinical concern as you go higher in the numbers. I'm pretty sure. Yeah.
Thanks for teaching me that.
Yeah.
All right. So I think that concludes our show. Thank you guys all so much for tuning in and watching. Thank you to all of our amazing faculty. And just as a reminder, our next show, January 10th, is going to be Emergency Medicine Grand Rounds. We will see you there.
Thanks, Britt.
Woo!
Thanks.